like to start the YOSI session, How I Made a Difference in Ophthalmology. And I would like to invite our first speaker, Dr. Divakan Mishra, sir, to speak on pivotal survey of VR training status. Yes.
So very good morning. So sorry for the delay. So I'll be talking about the pivotal survey which we did a few years back, which is the Pan India Vitro-Retina Fellowship Survey. Dr. Apurva, Dr. Nilesh and Dr. Avnish helped us with this survey. So India has a lot of very nice institutes that offer subspecialty training, especially in retina. When we conducted the survey, we found that almost 40 institutes were actively and regularly following up this course. So we conducted a survey. The purpose was to evaluate the surgical volume, training, and the experience of VR surgery fellows in India. Now we had a Google form which had around 80 questions, and we created a list of fellows across India and mailed them their fellowship directors, and we tried to mail them individually also this form. Now coming to the results, we got response from around 138 fellows. Now the majority of them, 64%, were female, the fellows at that time. The first question that we asked them, that why retina surgery was the choice for them, and majority of them chose it because they were very passionate about it. Considering the choice of institute, why they opted for a particular institute or why that was the number one choice, the number one point was the number of volume of cases that the institute provided them with. Coming to the working conditions, most of the fellows worked for more than 10 hours, and majority of them had to work at times on a Sunday. Most of them, around 60%, had 10 to 15 leaves, and the majority of them had a stipend of somewhere between 20,000 to 30,000. Now, almost 34% found the fellowship experience quite stressful, and the number one reason for that was that they got less time to spend with their family. Coming to the exposure per se, the assisted cases, if we talk about surgical cases, around 41% got 100 to 500 cases to assist, but they performed only, around majority of them performed less than 10 less than 10 cases in the whole fellowship duration. Then we talked about the different surgical things in there, the experience when it comes to that. Most of them did an okay number of buckles, but the other surgeries were quite less. Medical retina exposure was quite good. They got adequate number of lasers and intravitreal injections. Coming to the academics, most of them had around one session a week, and they could not find enough time to do some research. The number of manuscripts submitted was between 1 to 3 for majority of the fellows, and almost 60% could not publish any manuscripts during their fellowship time. Coming to conferences, they got to attend around 1 to 3 state or national conferences, and around 75% did not attend any international conference during the fellowship, and around some of them got the opportunity to present at these conferences. Now coming to the post-fellowship plans, it was good to see that almost 70% wanted to go into exclusive VR practice, and most of them, when we talked about the job or the employment they were looking for, the number one reason for point was the facilities, the infrastructure that was there at the hospital that they wanted to work at. Most of them wanted an institutional setup to begin with, rather than a government or a solo practice or an individual practice. Now we also asked them what they wanted in the fellowship program. Majority of them wanted a mixed kind of an entrance exam with an interview and a written exam as well. And the ideal duration they thought was around 2 years. And the ideal stipend was the last option, that is more than 45,000. So if we have put more options, I think that would have been the ideal. So we asked about whether they wanted a common exit exam. Majority thought it was not a good idea. And whether they wanted a central fellowship governing body kind of a thing. So majority of them thought that will be a good idea. So we also looked into the literature, and similar studies had been conducted by our American counterparts and American and European counterparts, and they fared a bit better than us. The average number of vitrectomies that they had done in a 2-year period was more than 400, which was way more than what an average fellow does in our country, and they had published on an average of over 4 papers. Similarly, in another study from the United States as well, we found that the number of surgeries done was definitely more than what we do, right? So coming to the end, there was a lot of disparity between all the institutes. Some institute gave a huge volume of surgeries, gave the fellows a good opportunity to publish and attend meetings, but there were most of the institute did not give this opportunity. Majority of them didn't have any good research opportunities. We could not find a uniform curriculum that was there amongst all these fellowships, and there was no surgical minimums. Like a lot of people had done 0 cases as well, right? So working on these points, I think we can help the AIOS and other bodies to help form a better curriculum for our fellows, and we intend to do this service for other specialities as well in the future. Thank you.
Thank you so much, sir. So thank you so much. I think the most important thing over here is that if you look at the academic exposure in terms of attending conferences as well as publishing papers, there's almost 60% who have only attended 1 to 3 conferences or have published 1 to 3 papers. So one thing
most of them didn't publish anything.
Most of them didn't publish anything.
Yeah.
And when you mentioned that the primary criteria was surgical opportunities when they're looking for the fellowship. So retrospectively, considering your VR fellowship, do you feel that high volume cases help, or would you rather suggest people who are listening to go for a more structured approach, lesser cases, but a more guided approach that is usually followed in the United States?
Right. So when I was in my fellowship, definitely the number one thing on my mind was to get more cases. But in retrospect, I realized that it's more important to do individual steps, especially in VR surgery. There are 5 to 7 basic steps. If you have done all those steps, maybe not in the same case, but still you can stitch things together at the end of the fellowship. For example, when I finished my fellowship and I joined a VR practice, the first case that was kept for me was an optic disc pit case, right? And of course, I'd never done that case, but I'd done vitrectomy, I'd done ILM peeling, I'd done gas injection, right? So I could able to do that. So because all those individual steps I could do them repeatedly, right? So it's not important. A lot of people think that I've not been able to done even a single complete case,
exactly,
right?
Exactly.
So I don't think so that is important. Volume is important. The more you get, it's better, but not at the compromise of other things, right? A lot of people leave everything else and keep running after surgeries. It's important, especially in VR. It's more important to do the steps, and if possible, if the numbers are good, that's okay. But not to worry if you don't get huge numbers, right? But in our American counterparts, they get a very large amount of numbers because
they're not allowed to progress before they complete certain criteria. They have a competency-based program.
Not exactly, because I was there for some time in the Stanford.
Yes.
So there, a person who had joined 6 months back, he had already done 300 cases.
Okay.
Yeah. So within the first 1 to 2 weeks, he was able to do quite a bit of vitrectomy.
Okay.
Yeah.
And maybe the people who didn't respond were the ones who were actually a lot busier with
That's actually a good observation.
So what we saw is that institute like RP Center, PJI, and other, maybe Arvind and other institutes, some institutes got a huge volume of cases, but majority of them, so there was a big disparity. Some were offering a very good program, but most of them were offering not a very structured program.
Right.
Yeah, why don't you all have short-term retina training courses, paid ones that are available like for cataract surgery? Why is there disparity that cataract can be taught for 1-2 months, but retina cannot be taught for 1-2 months?
Because, right, what we had in our institute short-term retina training programs also, especially from the people who come from the government, government doctors who come in for a training for 2 to 3 months. We tried to teach them, but there's a learning curve. Even you, for a good indirect ophthalmoscopy, you need at least 2 to 3 months. Somebody who's not, who's not done that enough. So even to get your diagnostic and clinical skills up to that mark takes time. Lot of our colleagues who are doing fellowship right now or juniors, some of them who had not done indirect ophthalmoscopy well in their residency, it has been 6 months and they are not very confident even with their barrage lasers and all that. So I think it has a learning curve. It takes time. That's why probably, yeah. And most of us don't get a good training or good exposure to retina in their residency. Cataract, most of us get it somewhat.
No, no. For example, I am a anterior segment surgeon. I want to also do retina, not the whole thing, but I want to be able to learn little bit of retina. So if I do a 2-3 month course to do that, but if a retina doctor doesn't know A to Z about cataract, also he can do a 2 month course and learn cataract by paying money. Why this discrepancy is there? I am confident that if I do a 2 month course, I will be good in doing. I will at least be okay in doing retina, but
No, the reason
no,
is
but
the
do you
reason-
mean?
Exposure for cataract
Yeah.
during
No, residency, exactly.
and then not all of us are exposed to retina during our residency, right? We don't get to do or assist retinal surgery during
True.
But you have short-term courses or intravitreal injections and all that. I think
Medical retina is there. For 3 months, medical retina courses are there. Some places I think do offer short-term, the kind of cases that you are talking about. Some people do offer it.
Also, when you start off with a surgical fellowship to get oriented with a biome and
Yeah,
the
that
entire
takes time.
setup and the inversion, I think that only takes 2 months. So by the time you start putting the cutter in full, your 2 months are done.
Yeah.
The other thing is that most of the cataract cases will be more or less same. There is nothing unique in that. But every retina case is a different
Is a different case,
So
exactly.
that needs a lot of experience and
And another thing is that if you land up in a complication in a VR surgery, then probably it will be difficult for even a VR surgeon to handle that. Yeah.
Right. Thank you so much, sir.
And at
So-
YOSI and especially our young leaders, we should, do more of these surveys, plan out and.
I think so
Yeah.
as well. So we'll go back to our regular schedule, and I'd like to call Dr. Aarti Heda ma'am to speak on outreach programs and serving the community internationally.
So, good morning, everyone. This topic is very unique and difficult for me to talk, but I'll try to do my best. Outreach programs and serving the community internationally. So, let's first talk about what is a community service. It is unpaid work performed by a person or group of people for the benefit and betterment of their community without any form of compensation. And being a doctor, we are expected to do this type of community work very often. And to some extent, we do this in our day to day practice. Let's say we have just prescribed a medication to our house help, or maybe you've prescribed a medication to your relative. So, that is also kind of a community service. So, according to the World Health Organization, at least 2.2 billion people globally suffer from some form of vision impairment, with at least 1 billion cases being either preventable or yet untreated. When it comes to cataract surgeries, it is estimated that around 20 million cataract surgeries are performed globally each year, with a significant portion supported by charitable organizations. So, let's talk about what can be done under community services. Outreach programs in ophthalmology that serve communities are crucial for addressing eye health disparities and providing essential eye care to underserved population worldwide. They play a vital role in reducing the burden of preventable blindness and improving access to quality eye care services. Outreach programs often begin with screening camps where trained healthcare professionals screen individuals for common eye conditions, let's say cataract or refractive errors. These camps are usually set up in rural or underserved areas where access to eye care is limited. Once individuals are diagnosed with eye conditions, outreach program provide treatment options, let's say doing a cataract surgery. So surgical camps are often organized to provide free and low cost surgeries to those in need. So the outreach programs also focus on training of local healthcare workers and ophthalmic technicians to enhance their skills so that the system is not dependent. So there's long list of organizations that are doing community services at this stage. I mean, it's not possible to cover for anyone how long the list is. Few of them who have been popular are Orbis, Sightsaver, Seva Foundation, then Operation Eyesight Universal, and there are a lot many groups from US. They do a lot of community work, like one of them I am associated with. So how can you do a community service? You can give your clinical and surgical expertise to treat the patients directly. You can be involved in teaching activities and be mentor to students and budding ophthalmologists. You can provide training to the healthcare workers or volunteers on the basic eye care practices, let's say just to identify a common health disease. If you have, let's say, if you have come to a stage where you can support these things financially, then maybe you would like to give the financial contribution as well. So the very important question asked to me at least is, how do you enter these organizations? It is very difficult. It is not very easy, let's say, to catch up a good group and then be associated with them for long term and do the community service. So what you have to do is you have to keep looking on the options, keep looking on their work, keep following their work, write them an email and ask, say, hey, I'm this specialist, do you need any helping hand? I have been trying to write one kenyarelief.org. I must have written them 10 emails, and every time I get the response that no, we are not in need of any anterior segment surgeon at this stage. So there are a lot many organizations, they go to remote areas, especially in Africa. So it's the best way is to just follow them, write them an email. The other option is you can speak to your mentors. They might know lot many people, those who are doing community work. Like I was talking to Dr. Santosh Shunawar sir a couple of years back, and then he says that why don't you talk to Dr. Sangwan? He does he has done a lot of work with Orbis. So talking and discussing with seniors can also open up a lot many options for you. First of all, you need to ask yourself that why do you want to do this community service? Somebody who has just finished the fellowship and might not be in stage to do a lot of community work for the reason that he has to earn as well. But then the other thing is that he might say that, oh fine, let me go to a remote place or let me go to Africa and let's get a lot of hands-on. So it depends entirely on you that why do you want to do it. How frequently you can do it, second question is you should ask yourself. You can't say that I'll go 1 month and live in Lebanon, and let's say I'll come back in 1 month back to India, and then I'll have my own practice here. It doesn't work that way. There has to be a continuity wherever you are. Let's say if you are in an organization, they won't allow you to go for a month and come back and join them. So it depends entirely on your situation, how much charity you want to do, how frequently you want to go, when do you want to go, and for how long can you do this. So there are various challenges at personal and professional level when it comes to community services. So if in case I am traveling to one particular country, I'll have to have a license to practice in that country. I'll suggest that don't touch a patient if in case you don't have medical license or let's say a special permission from medical council over there, because if in case you land up in a trouble, it will be difficult for you to come out yourself unless you are with a group who definitely is going to take care of you and bring you back to the country. It's not that I want to scare you, but just be careful. There are a lot many consumable issues. You feel that fine, this group is coming from US, so they can bring up lot many things over there. But believe me, it's not possible to get at times the things which you really need to do simple surgeries like viscoelastics or Blurex or mitomycin C. So be prepared that if in case you don't have a good phaco machine, you should be able to do a good SICS surgery. Have your expertise for that. Like I travel to Tanzania for surgery, so I carry many SICS sets with me because I've seen that they don't have adequate instruments, and if in case I have to do back-to-back surgeries, then sterilization is a problem. There are a lot of personal issues as well, challenges as well. I say that when it comes to community work, you have to leave your family back in India and then do this community work. So supposingly you have a child of 1 year and you say that I want to go for 10 days. So you'll have to have a good support system back here to take care of your family. You'll have to always have that risk of infectious diseases, which is very common in eastern part of the Africa. So the topic given to me by Karan was this serving the community at international level, because I have been doing some work at international level. So I have been associated with Africa since the year 2016. And I have worked on both these sides. So I have worked with a corporate hospital as well as I am doing the community work. So not to boost myself, I just want to share my experience with you. So this is from my recent visit in Tanzania, and this is one of my very happy patients, first day of SICS. So the NGO I am currently working on is based in US, and they have these visits every 3 months in remote places of Tanzania. So we went to a place called as Songea, which was very far, and when I came out of the aircraft, I was already on the main road. So I just realized how small the airport is. I literally survived with white rice and bhujia save there for 10 days. I lost 2-3 kgs of weight over there. But the service which we gave over there was really satisfying. So we did a lot of SICS surgeries. We saw a lot of patients related to glaucoma and retina in OPD. And the best part of the visit was to train the residents over there. So the rule is of the organization I work with that we don't have to operate everything ourselves. We have to teach them so that when we come back, the system is not dependent on us and we are leaving something back over there. So these are some of my very happy patients, and of course we all have our sets of testimony and all from our patients. So there was this issue by Nupur and her team, which was published by YOSI YO Times. It had experiences of many people, those who have worked at international level. This might not be related to the community work itself directly, but it definitely gives you an idea that if in case you want to move outside the country, what all options you have. So it's a very good read. And yeah, of course, I have also written a chapter in this. So thank you once again, and if in case you have any questions, I'll be happy to answer.
Thank you so much, Aarti ma'am. So firstly, I would like to congratulate you and commend you on the incredible service that you've been providing for the last couple of years. So 2 questions just for the benefit of the audience. So what were your 3 most challenging situations over there? They need not be related to ophthalmology. You can mention related to your travel as well. And secondly, for those just listening in, many of them are probably inspired by you and would probably want to take up something maybe even this year. So is there one place that you would recommend that, okay, just start here, other than the YO Times issue that you have mentioned?
Okay, so when it comes to challenges, you want me to give 3 challenges. So I'll just share a small experience. So when I was going for my last visit, I was at the Mumbai airport and I was holding my boarding pass and passport, and I just kept it, and I was trying to just organize myself for the security check, and somebody picked my passport and I was not able to find it. So I almost went on the panic mode when somebody shouted that, oh fine, I have your passport. So this was one. Then I went to the airport in Tanzania. So it was a domestic transfer. And the security guy says that I have given you, the check-in guy says that I have given you your passport. And I say, I don't have it with me. So I actually went on panic mode that what if I lose my passport here? Though it was just a small thing. So finally they found it and I got it after 30 minutes. I went to a hotel to check in over there, and there was another Indian who was checking in with me, and they gave my passport to him by mistake, and he did not find a room over there. So he left from there. So So when I'm asking, where is my passport? They say, oh, we don't have your passport with. So this has happened in the one visit. And believe me, it was very difficult situation for me emotionally to handle that, oh, what will I do without a passport? The second challenge I told was food. Food was a very big challenge. I thought that maybe my parents won't allow me to go back if in case I lose 10 kg over there and go back. The third challenge is trained staff. So it is very difficult to work with somebody who is new and you are expected to do all complicated surgery, let's say 30 surgeries in a day. You want to work on your own speed, you want to work in your comfort zone. But it is, the communication itself is difficult. You take a lot of time to train them. You have to be very slow, very gentle with them. So the work culture is also very different.
So every time that you went there, would you train different residents?
Yes, so I have been to different parts of Tanzania and I have not repeated the hospital yet. So every time you have new sets of residents, every time you have new sets of staff getting trained under you.
Right.
And day one you start and you'll realize that how much work you'll have to do with them so that by 10th day they are trained enough so that they can work together, the resident and the staff.
Right, right. And what's the maximum duration you spent at a single go?
12 days.
12 days. Okay, that's excellent.
But then I have been based in Africa for 3.5 years. That was a western part of the Africa. So this is what I'm talking about is Tanzania for my community work.
Right, right.
Sarthi, I would assume that there wouldn't be any VR backup when you're performing these cases. So what happens?
No, we don't have any VR backup.
And again, I would assume you wouldn't have had any complications. But if someone would have them, what do you do in that case?
So most of the places we operate, they have air connectivity. So the thing is that Dar es Salaam has a lot of VR surgeon, 4 VR surgeons. So we've spoken to them, like 2 of them are very good friends of mine. So if in case anything happen, we have that backup that we can fly the patient to a VR setup and we can get things sorted. And we have basic vitrectomy machine over there. There are 3 machines so that if one fails, the other can be used. And basic anterior vitrectomy and let's say secondary IOL, those things the surgeon there can do. Like I'm one of the chief surgeons, so I can do.
So 4 is a big number when it comes to VR surgeons there.
Yeah.
Surgeons, 4. Yeah.
So I have 6 on the road that I practice in Lucknow.
Have you had any issues with sterility?
No, not yet.
Not yet. Okay, thank you.
But the one of the photo, if you would have noticed, I was just walking the hospital I visited last time. I was just walking with my dress and footwear, and I just realized that, oh, I'm in the theater. I'm like, okay, fine. The theater.
Right.
So I didn't even realize that I've entered the theater. So yeah, but then we've changed many things over there. I'm grateful to ICORPS and Dr. Susan. She's got a very good team. So we've changed many things in definitely few parts of Tanzania as of now.
What's the patient attitude towards doctors coming from other countries?
So I have spent a lot of time in Africa, and I'll say a big culture difference when it comes to patient. So let's say I've operated an end-stage glaucoma patient, assuming that the patient might get some vision or let's say ambulatory vision. If in case I've not got the result, I was disappointed, but the patient will come up and tell me that, you know what, doctor, you have done your best. So don't worry. I know that you have done your best. So the attitude of patient toward you is like you are actually a god for them. And I have seen this lot of difference between our culture and their culture. So if a patient is walking inside your OPD, we tend to just ask, ki kya takleef hai, what complaints you have, and we are not even bothered to greet them and all. But then if in case you forget to greet a patient, they'll greet you, of course, and then they'll ask you, how are you, doctor, today? How's your family? So this exchange of greeting and many these small things which I have picked up from there is something which I really want to continue for rest of my life, even in India.
Right. Okay, thank you so much, ma'am.
Thank you so much.
With that, we move on to Dr. Dipanshu Agarwal, sir, and he will be speaking on medical legal survey by YOSI.
Very good morning to one and all. So this was another survey which we did in YOSI, and I would like to present the results of it. But before going on to the topic, I would like to ask how many of us attending this session do have awareness about indemnity insurance, and how many of us actually have it?
Yeah, same.
Puneet sir does not
I
have.
don't know the
think.
nitty-gritties of it, but I still took it.
John, do you have indemnity insurance? I think one of our primes, only Puneet sir. All right, so I'll be discussing the survey results which we had conducted a few years back. So it was basically developed using Google Forms and circulated to YOSI members and other non-YOSI members as well. And it was available for a period of 6 weeks, and we had evaluated the results. So basic demographic was the mean age of the respondents was 38.4 years, and slightly over 50% were male. 75% of the respondents were YOSI members and rest were non-YOSI members. If you talk about the age groups, more than 40, it was 3:1, like YOSI matching with the number of YOSI respondents. Less than 40 years were almost 76%, 74%, and more than 40 years were 26%. If we talk about practice setting, majority of the respondents were from South and Central, like forming almost 56% of the respondents. And if we talk about the practice setting, majority of the respondents who responded were from the solo private practice or group private practice, and including private institutes. If we talk about the designation at workplace, almost 80% of them were junior consultant or senior consultant. If we talk about, we also, when we asked them about the awareness regarding the professional indemnity insurance, 82% of them were aware, but it was surprising to note that only 54% of them had professional indemnity insurance. When we compared this awareness versus awareness ratio versus actually having the indemnity insurance across different groups, in the age groups of different categories, there was statistically significant difference between all the groups where there was awareness of it, but only few of them had possessed it. Similar difference was noted across male and female gender. Maximum, like most of the male respondents were aware of it, but only 65% of them had the indemnity insurance. And similarly, in females, the ratio was almost similar. If we talk about zone-wise distribution, again, this was a statistically significant figure across all the zones. And if we talk about when we compared it between in amongst the different designation, only most of them were aware of it, but there was a very low possibility of having the insurance in the younger generation, since they are lesser aware about it. And similar results were noted in the practice setting. So when we asked them that have you, out of the 109 respondents which we had in the survey, have they faced lawsuit? 2%, which I feel is a significant number when it comes to lawsuit. And they found that process of hiring and the most challenging part was process of hiring lawyers and court works was not very smooth, and they had faced difficulties in that. And when we asked them about would they be interested if legal help is provided, almost 94% respondents were agreeing for that. And also, if they wanted, they would be interested in webinars and teaching courses if they are being conducted on medical legal aspects. And then the next important part is insurance companies and legal service providers. So insurance company basically covers the final compensation amount that has been filed against you. If the court has given notice to you to give this much of compensation, that insurance company takes care of it. Then there is a separate segment, that is legal service providers. They take care of all the parallel or para-legal activities, like arranging a lawyer, doing the paperwork for you. All those activities are taken care by them, and you need not worry about the practice, because if you have to go to the court every day for every small little work, that will hamper your practice and mental peace. So apart from insurance, there is another entity called legal service providers. So most of the insurance, like if we only 59 respondents had insurance cover, and out of that the companies which they most of them opted were ICICI Lombard and United India Insurance. Then coming to the legal service providers, so they charge a minimum fee like say 3 to 4 thousand per year, and then they take care of the rest of rest of the things that they'll get you, that they'll do the paperwork for you, they'll arrange a good lawyer for you. If you are not satisfied, you can have the lawyer and they will pay the fees for that. So all those things you do not have, like you will have to shell out very small amount, but these comes in very helpful. So service providing agencies, there are many. There is Medico, there is AMC, there is Apex Consultant, there is IMA, there is by Doc Shield, Medef, Maharashtra Ophthalmic Society also has it. But out of the 59 respondents who had insurance, only 30 had taken these help of these legal service providers, and out of that, AMC and IMA were the topmost top preferred options. Then again, the another question arises is how much do we should ideally have the cover. So most of the respondents, like almost 40 to 50% had a cover of 1 crore or more, and almost 50 to 55% had 75 lakhs or lesser than that. So our ideal thing, because there have been multiple lawsuits now being filed against Indian doctors as well. Earlier it was famous in, like, it is pretty common in US, but now in India also doctors are getting sued for this. So for us, from our point of view, if you have, because the compensation amount, especially in the retina segment and ROP, there have been a compensation for around almost 1.5 CR also in one of the case. So ideally recommended amount from our side, from the survey what we analyzed, is it should be 1 crore or more. You should always, it's a good thing to have these service providing agencies as backup, because they will save a lot of money and lot of energy of yours, and you can still continue working at your normal pace without taking headache for all the parallel activities. And you should understand the terms and conditions, discuss with them, discuss with peers, because Anujit might be more knowledgeable about this and he can help you with this. And again, to save all of this, good documentation is the key. Thank you. I would like to acknowledge YOSI and YOSI core legal team for this survey. Thank you.
Thank you so much, sir. So the last line, good documentation. I was in a session, I think yesterday, where they mentioned, where the key takeaway was that in your prescription, if required, write less, but write legibly, because a doctor could not recognize his own prescription and what he had written in court, and he was fined for that. So that's one important takeaway that I had taken from that session.
Yeah,
that
another
I would
thing
like
is,
to share.
even if you have not said it, you should have it on the paper.
Exactly.
That will save you.
That's one important thing. So you've mentioned a lot of advantages and a lot of nitty-gritties regarding the insurances to take. So are there any red flags to always ask these insurance companies before you choose them? Some things which you have seen.
One thing which when I was opting
regarding
for it,
claim and things
yeah,
like that.
claims, and another thing is there is something called civil case and criminal case.
Right.
So there might be some criminal cases also being filed against doctor. So few of the insurance, these companies take care of it, and few of them do not.
Right.
So
exactly.
it's better to have both on the panel, because patient might file a criminal case also against you. So that is one thing I realized.
And would you recommend any other source, any online source, which would have more the legal aspect of it? Because there are a lot of webinars from doctors who are explaining this. But is there anything in your survey
I have
that
not
you
come across any other?
What was the question?
So, is there any legal source that one can read about medical indemnity insurance? Because right now, most people follow webinars and follow seniors who give them advice.
So there is not any, as of now, there is not any official course, but you do have PGDMLS, PG
Right,
Diploma in
right.
Medical Legal Services. I did this course during my residency.
Okay.
So that time I was actually got awareness that fine, this is very, very important. But there are many short courses, and there will be one course which will be coming up this year probably, which will be on telemedicine and its medical legal aspects. So
okay.
those kind of courses will be very short. But this PGDMLS course which I did was a 2 years course. It was that I had to write an exam and all. So there are many courses. There is another course which is by which Anand sir was suggesting us, that it is MBA, which is related to medical legal services. That is also a 2 years course, and there will be 4 semesters, 50,000 for each semester the fees is. So it is something which is very, will be very recognized course. So if somebody is interested, we can definitely share the link if needed. I just wanted to add one point. We spoke about indemnity insurance. So if in case you have your own hospital and you are working over there, so you have to have indemnity insurance for yourself and your as well as your hospital.
Yeah.
Forget about your staffs and all. So let's say patient can put the case on
Doctors
you
as well
or
as
your
the hospital.
hospital.
Yeah.
So now if in case you are employed in a hospital, so it becomes hospital's responsibility to have insurance for you.
Right.
So the doctor can't sue the the patient can't sue the doctor over there. Even if the doctor is sued, he can be easily he can come out of that case, because the patient has come to the hospital. He doesn't know who will be the doctor. He doesn't have choice of the doctor. So his direct contact is just with the hospital. So it's kind of, you know, with whom you are taking the service. The doctor is giving service to the hospital. So there is connection between hospital and the doctor. The patient and doctor can't be connected in this case.
Right.
So I have
Yeah.
one question in that regard. I'm loud enough. So the thing is that when I was with my first when I was in my first corporate job, that was center of site in 2018, and I had my own professional indemnity. I did not have any cover from the organization.
Few of them cover, few of them do not.
Now
have a cover,
in my current
actually.
organization, my policy was lapsing, the one that I had, which had been continuing since 2018. I let it lapse because I got another cover from my organization. So I think it's the place of work in the indemnity that is important. So now my policy says that these so and so branches of Shopside Eye Hospital are covered under this policy, meaning that if I operate at this hospital, then I'm covered, and if I don't, then I'm not covered. So should we be having two policies?
You can.
No,
You
should we
can.
be having two policies?
No, you
Just in
can
case
have
if
it
you're
from.
operating somewhere.
If you are operating at different center, obviously you will have to have that backup, because that won't cover. The sharp side
No.
policy won't cover you.
So the question I was arriving at was that now that I have an insurance from my organization, which clearly mentions that I don't operate anywhere else. So if something happens, then it's going to be directly against me, not against the hospital, right?
No. You
So
are covered.
that's what I want to say. That it depends on the patient
Uh,
whom he is putting allegations on. If he is saying that Dr. Pureen Jain, I want to put allegations, so it's between you and the patient. Now it depends on what terms you have with your hospital in this case. So if in case you say that this hospital has employed me, you can be saved in the court, though the patient has put the case on you.
okay.
The patient should be putting the case on the hospital, and it's between you and the hospital how you deal. Now when it comes to indemnity insurance, I personally feel that you should have it for your own self. The premium are very, very less nowadays. Like 2,000 rupees mein you can get cover for 25 lakhs. The minimum amount which we'll suggest you should take is 1 CR. Now if in case I am traveling outside India for surgeries, so I should have indemnity insurance which is globally applicable. So there are some companies from Mauritius, they give global indemnity insurance as well. So it is how you secure yourself.
No, but then having two policies, how does that
You
help?
can have.
You can
How
have.
does that help?
No, because it will help you outside the sharp side.
No, that is not happening. Na? So if I'm not operating outside shop side,
Huh.
and if I'm operating within the bounds
Then you
of the-
don't have to take, because
you don't
you
have to
already
take.
your hospital has already
Yeah, so
taken, no?
there's no benefit of having an individual policy, right?
No. When
There
you are-
won't be any benefit. Like if
Yeah, right.
So the IMA has sort of not exactly an indemnity insurance. They have some sort of legal support and all that. And so if you have the IMA support as well as an indemnity insurance, I think IMA will take care of the legal
that's
challenges.
what
In case you have to pay, you lose and you have to pay, then the other one kicks in. Am I right?
Insurance company pays for the compensation which has been awarded to the patient, and lawyer fee, paperwork fee, everything is taken care by these legal service providers.
so the other thing is that the insurance companies, they also have their own lawyers nowadays. So they don't want somebody other coming up and telling that we have lost the case and we have to pay this much of compensation. But in that case, you can always say that I want to have my own lawyer. But these insurance companies nowadays, most of them, they have their own lawyers for these things. So it is definitely good idea to have indemnity insurance. There's no doubt about it.
Right. Thank you so much. So we'll move on to the next talk. I'd like to invite Dr. Puneet Jain sir to speak on international registry studies, my experience with conjunctival melanoma.
Hi, good morning, everyone. So, it's a very broad topic, and let's start. Let's start. So, I thought how to cover this topic because there's so many aspects to being a part of registry, doing this stuff, then analyzing the data and coordinating with people. So let's put some things into perspective. So a bit about conjunctival melanoma to begin with. How I got interested in this, registry, and eventually what came out of it. It's a very rare ocular tumor. So just 0.25% of whole body melanoma, 2% of ocular tumors, and just 5% of the entire ocular melanoma. The incidence is 1/20th of cutaneous melanoma and 1/10th of uveal melanoma. We barely see uveal melanoma in our practices. Imagine seeing conjunctival melanoma in your practices. And that's not the case just with us. Even in the West also, the numbers are very low. So the incidence is on the rise. There have been a lot of studies which have shown that there is a fourfold increase in conjunctival melanoma cases over last 4 decades. And this is in stark contrast to uveal melanoma, where the incidence has been pretty much stable since COMS came out back in 1980. The metastatic rate and the tumor-related mortality remain very high despite doing everything, doing no test technique, screening the patient. So there's something that is missing in the chain, which needs to be found out. Now, just this is an incidence chart. Thankfully, we are not on this map. It's good to be not on certain maps, because the incidence of melanoma in our population is less than 0.24 million. But if you see this, just to give you a, like a view from 40,000 feet as to where melanoma resides in the world, and you see that US, Canada, Europe is heavily, very high incidence of conjunctival melanoma, and Australia as well, a lot of patients. So it is natural to draw comparison between various melanomas, and biologic behavior of conjunctival melanoma is resembles cutaneous melanoma more than uveal melanoma, which is very important because then the therapies for both the tumors become very different. So how the concept of the registry came through was, it was the first eye cancer working day, one of the International Society of Ocular Oncology conferences, cancer working day in 2015, where there was a hall full of 168 eye cancer specialists who decided to discuss certain projects. And one of the agenda was how to mine data for these rare tumors, because even if you have a prolific practice, single oncology setups like Dr. Shields has, even then, it's very difficult to churn out big numbers for such rare tumors. So it was decided, and a lot of people came on board, and eventually we had 10 centers across 4 continents. 3 were from North America, 2 were South America, 4 from Europe, and the Asian representation was from Jordan, King Hussein Cancer Center. A lot of people were involved in this study. So let's go through the foundational elements. How does such a registry work? So it's an internet-based data sharing registry, where all the centers sat together, all the heads sat together, and they decided what are going to be our data fields, so as to we can get some meaningful data and analysis out of it. What would be the inclusion criteria? All the patients. So the timeline set for this registry was 2001 to 2013. So this was the time when genetics of the melanoma was not into vogue. Right now we are too much into that is the way forward. We'll be covering that a bit in the last few slides. And also systemic immunotherapy for conjunctival melanoma had not taken scene yet. Those two things have changed since then. And then there is ethics board approval, contractual arrangements, and to secure the data online. So that's also very important. Now this is how the main sheet of the registry looked like. So there were 4 main tabs. First was the staging criteria, which used the 7th edition of the AJCC classification, which eventually got revised to the 8th edition in 2017. Then was staging, calculation, treatment, and outcomes. So everything was being filled in a very precise manner. And these are few examples from the sheets as to how the data was filled. So it was either a yes or no question, or there were certain description boxes wherever required, so as to give additional information. So data security and patient study privacy were very important. Obviously, there were no patient identifiers. Every patient was given an ID number which was accessible to the local center. There's something called SSCL, which I learned to learn a bit about, which helps us prevent any information being viewed by somebody else. So these are basically secure packets which keep the information so that nobody else can access the information. Then there are user permissions. So only one person from the entire center would have the access and would have a unique login and password so that nobody else can access the data. There's something called record locking, wherein only one person can access from one center at a particular point of time, so that there is no corrupting of data and there is no overriding of any data. And there are automatic audit trials that happen, and they are secured as well, which are not available to everyone to be seen online. Then comes the last most important thing, mining the data. So you've collected so much data over a period of time, and it's time to mine and get to some meaningful results. So we did come out with 2 papers so far from the registry. The first one spoke about the validation of the 8th edition of AJCC, which had just come out then 1 year before the paper, as to how much relevance practically the new edition has, and the changes that came out, the transition from 7th to the 8th edition, did it have any relevance. So we did come out with certain starting points which gathered a lot of limelight because they were opposed to the conventional teaching. Then the second paper spoke about all the local treatment outcomes of these patients, and we saw that tumor metastatic could occur as late as 10 years after the initial treatment of the patient. So long-term follow-up is mandatory in these patients, and they do come up many years after their treatment with a systemic spread. Now with the third paper from the registry is almost wrapped up now, which spoke about metastatic conjunctival melanoma. We're not going to go into details, but the important point to remember is, when you're practicing as well, is that more than 50% of the patients, they develop metastasis without local recurrence. So it's been always a dictum that if there is no local recurrence, the patient is fine, you don't need to follow up, you don't need to get a PET scan, or if the patient can't get a PET scan, then at least the basic workup of a chest X-ray, ultrasound abdomen. We tend to get lax or lenient with patients, especially after 2-3 years of regular follow-up. Everything is fine, there's no local recurrence, but one has to be mindful of the fact that these tumors can occur without local recurrence. Another thing, this I have already spoken about, and with every 1 T stage increment, there was an 89% higher risk of metastatic disease. That is a huge jump for 1 stage. And with every 1 millimeter increase in thickness, there was an increase in 16% in the rate of metastasis. Now this is again very important. Sometimes we see thick pigmented tumors in our OPD, and we might not evaluate them as well as they should be, and the patient might be harboring a melanoma, especially if it's a suspicious nevus, which we all see in our OPDs very frequently. So another starting point that came out of the registry, which is again opposed to the conventional teaching, was that a lot of patients had systemic metastasis without nodal metastasis. So there was a skipping of the nodal metastasis. Now the conventional teaching says that first check the nodes. If the nodes are fine, then you don't need to do anything. But then in this cohort of 29 patients out of 288 who developed metastasis, more than 50% of the patients had did not have any nodal metastasis. So that's again a very starking and debatable point, but then we are not doing good with respect to outcomes of conjunctival melanoma. Maybe this is the missing link in the chain. So that's one thing, and we've wrapped up this paper. Hopefully it should be published in a good journal. Otherwise we'll publish it somewhere in the 17th or the 18th attempt. That is the usual dictum these days. Especially when you bring about controversial points, they don't go down well with a lot of people, reviewers, which is obvious. Now coming to the last bit, what is new in conjunctival melanoma? So a lot of genetics has come up. These are the 3 most common mutations, BRAF, NRAS and TERT mutations that are commonly seen in conjunctival melanoma. They have already been very well described for cutaneous melanoma. Like I said, that we are taking a leaf out of the book from of cutaneous melanoma, and we've started treating similarly for advanced and metastatic conjunctival melanoma as well. So this is the MAP kinase pathway, and these are the checkpoint inhibitors that are being used in systemic immunotherapy in both metastatic conjunctival melanoma as well as in patients with locally advanced disease who would probably undergo exenteration. Systemic immunotherapy is being tried. So just to summarize, the way forward is basically to profile these tumors genetically, to understand what are the new targets for therapy. Then tumor resistance is again a very major factor. These tumors stop responding very soon to these immunotherapeutic drugs, and then to determine what would be the optimal combination or sequence of these drugs. And I see that genetic profiling and immunologic profiling would become a dictum in next 5 to 10 years, where all patients of conjunctival melanoma would have a genetic profile with them, and this should help us solve a lot of queries which are still persisting with respect to conjunctival melanoma. So I'll wrap up saying coming together is the beginning. I think that applies to YOSI as well. Staying together is progress and working together is success. So I think this is what highlights our registry. Thank you so much.
Thank you so much, sir. I'd like to invite Dr. John Davis Akara to speak on incorporating simple innovations in practice. So, Puneet, sir, one question for you. So, genetic and immunological profiling, how far do you actually think practically they are far off? Or do you feel that studies are being done and work is being done?
So if we take just last 5 years, there are at least 10 major publications
Right.
that have come out of in this with respect to genetic profiling. And if you see in India also, when I was a resident, there was just MedGenome doing some tests of genetics. Now there's so many genetic labs, there's so much competition in that field. We have more access to tests, the tests are cheaper. That is very relevant to our scenario because money somewhere is a constraint for so many patients. So I think we are in a good stride, and in another decade, we would have a totally different view of congenital melanoma.
Right. Thank you so much, sir.
So thank you to YOSI for inviting me for this talk, and it's something which we as young ophthalmologists really need to know. That is how to incorporate simple innovations into your practice. How and why? So I have no financial interest in this presentation, but a few of the apps which I mentioned have been made by myself. First, let me just talk about how I had all this engineering stuff in my profile. So I had always been from school days a programmer. I have been always interested in the engineering side, the computer programming side, and I've programmed with all these languages: Logo, Turtle, GW Basic, Q Basic, C++. But I had to take up ophthalmology, family practice. So I ended up being an ophthalmologist, but having all these extra things on this side. Even in medical school, HTML, JavaScript, we made a website called Medico Zone for PG entrance preparations and all that. We had an actual forum over there in which we had people coming in and joining and prepare for the postgraduate exams. And I had also done some programs in Flash and ActionScript, which is supposed to be for animation, but I made a surgically induced astigmatism calculator because a postgraduate in ophthalmology there knew that I was going to be taking up the ophthalmology, and her thesis had some issue because the software which you were supposed to use was not working. So being the tech support guy, there, I was asked to help with opening the software. I realized the software was corrupted, so we just sat and made a new app then and there. And of course, period of gestation calculator, that was during my OG posting. We were told that we could, as final year PGs, we could finish the calculation of period of gestation and EDD for all the patients there, and then you could go for T and come back. So we just automated the process. We never told the OG PGs what we were doing. So from my batch onwards, all the people, all the MBBS students posted there were going for tea very early, finishing off all the work, going for tea, having a lot of time to chit chat and come back just in time for the class. So that is what we did. And residency days, of course, iGrader app for all the grading systems. I know Tamil because when I was in Arvind Pondicherry, I found it relatively okay to learn Tamil, but I found people from many other places who found it very difficult to learn Tamil, including people from Kenya and many other parts of Africa. They came here because, like Dr. Aati said, there are very few doctors, very few ophthalmologists there. They needed to learn as much as they could in a short time. So Tamil was very difficult for them. We made I Know Tamil, I Know Bangla. So these are the apps for communicating with the patients in these languages. iDoctor, JD, 3D Atlas of Ophthalmology. These are all the apps which I made during those days. Coming to the clinical practice. In a typical eye clinic, you have the history taking, general exam, vision, eye exam, anterior, posterior, and the other tests. So what can you do in these things? So necessity is the mother of invention. During the COVID lockdown, we had a lot of problems with social distancing. So there are some apps which we could use during that time. We were trying to reduce the direct contact, reduce this thing. So patients were asked to, before meeting the doctor itself, get a history done on a, what sort of complaint they had and all that. And language barrier, we saw the apps which I had mentioned just before. And these are things which I have not incorporated but could be used in case of, the situation arises. You could take pulse rate on a standard phone. Of course, you can do it on a watch which has a pulse oximeter. But if you don't have any of those things, you can still take the pulse rate by using the smartphone apps such as this. And there are things which can look at the images and grade the icterus and anemia. Not really use it myself, but definitely something which could be done in, so suppose you are in a place like Tanzania and you don't have any other support, you could use these apps to get a general idea of what the situation is. And of course, visual acuity, there are these charts. You could use an iPad and an iPhone and use the iPhone as a remote control for the iPad, and that would be a vision chart in itself which can do all these tests. So this is something very portable and you can use that. Then of course, the peak acuity app, they made it very easy for illiterate patients to be analyzed. So you just ask them which way is the E pointing, and you just slide the finger in the direction which they said, and that makes visual acuity testing very easy to learn, do, and also to teach others to do. So I think you might have found it useful in some places to take visual acuity with a peak acuity app. Stereo acuity is something which is not easily doable, but there are apps which can do that. If you want to get stereo acuity testing devices, they are very expensive and they are very used very rarely. So spending so much for something which is used very rarely, unless you are a super specialist who is going to do all this 3D testing. So this is something which can use. You can use a random dot stereosis testing app, the NTU RDS screening app. And refraction also, if you do have a full set refraction with you, you use that. But then these are the things which you can use, the smaller, portable, less expensive ones, and these can definitely help you in your practice. Ocular examination, you can do measurements by using these things. So this was what I had presented way back in 2018 and in TNOA. So there is an app which we could use to do the measurements if you have the scale on there. So you just have a reference marking and you can measure anything else in the picture. And of course the eye positions and the head tilt, eye tilt, all those, the 9 gaze, everything is an app nowadays. So I'm going faster as the time is short. Anti-segment photography is something which I very regularly use. I use it to counsel the patients. So I take a photograph, show the patient, see, this is what you have. That really helps when you're new into private practice and they see that you don't have any gray hair and which you are a junior doctor, what do you know? So you take a photograph, show them, and that really helps in the patient rapport. And of course you can use all these devices. There's the IOL which is used for the ASPE. Dr. Prithvi Chandrakant has used the discarded IOLs for photography. Dr. Nilesh Kumar for gonioscopy, you have the DIX Pro. And the toric IOL marking is something which as a young ophthalmologist stepping into private practice is not something that you can afford to buy the Verion or any of the expensive gadgets. So learn to use the apps, the free apps. Dr. Saurabh Patwardhan has one, and of course there's iToric Patwardhan, and of course there is one by Dr. Jitendra Jetwani. Yeah, there is the one Jet Bros. So all these apps really help you to go into the premium IOLs, the toric IOLs, without spending too much money on the gadgets. Fundus examination, you can of course avoid taking a new fundus camera until you can afford it. So you can use a fundus camera such as the foldable fundoscope. This of course is the first version. The latest version has inbuilt illumination, magnetic docking and all that. So that is something which you can definitely use for your private practice. You can do it in your clinical practice. And keratometry is also possible. It's not very accurate. So there is something which I did called Keracan Mini Top, which can be used for getting a rough idea of the topography, and it is still under further development. But yes, this is also something you can have. Perimetry, we had the virtual reality perimetry. We started it in Arvindai Hospital, Pondicherry, with a regular virtual reality headset, which is not very expensive. So less than 1,000 rupees plus a phone with a Bluetooth clicker. So we use a Bluetooth clicker just because we had it, but we could even put in a earphone, the wired earphone. Those days the phones had something called a 3.5 jack. I don't know if you guys know about it. So that could be used to feed in the input to the phones, but you can do it with Bluetooth nowadays. So all these were things which were very low cost, very frugal innovations, or frugal innovations, as Dr. Santosh Hanover used to put in the IJO. And of course there are some more things which I do have some more time to use. Yeah.
You do have time.
Yeah. So we have put up several things in 3D models. I have designed these and put it for free on the NIH website. So if you scan this QR code, you can go to that website. Over here is the National Institute of Health USA's 3D website, and here is the Thingiverse. It's a general purpose 3D website. You can download these designs and print it for yourself. You don't have to know anything much about 3D printing. You just need to know how to use Google Maps. Google Maps, search 3D printing shop near me. Go there and tell, "Arey bhaiya, I want 2 printouts." And just tell them printer, download, print 5 copies. So they'll print and give you these things. So these are not paper, these are plastic models, 3D models, which you can use. My idea is that you can use these in the wet lab. So that will be the first step. You use these in the wet lab, but there is a step 0. You can use these in your PowerPoint presentations. There are these new PowerPoint things that you can use 3D models within the PowerPoint itself. The same thing which you can 3D print instead of, so if you don't want to 3D print, if you don't have you can just use it in your presentation. So if you notice here, these are 2 3D models which I put, and look at the next slide. They just move in 3D. So you put it there, put it in morph transition, you can transition them. So yeah, you can use this for your 3D presentations as well. And then we printed some new designs of glaucoma drainage devices. So all these can be used for innovating new designs of any ideas that you have. Suppose you have an idea for a Divakant chopper, but no, you're a posterior segment. So you want to do a Divakant peeler. So, so you make a Divakam peeler, draw it on paper, then you draw it in 3D, and then you print it out, test it out, you figure out what works, what doesn't, then you realize that, okay, it needs to be having a bend at this point, and maybe the bend is not enough. So you iterate, and then once you iterate, you can again redesign, print it, redesign, print it, find what works, then patent it, and then go to the company and get it done. So that's how you can do your innovations, make it from a dream into a reality. This is a very interesting case. So I was in Ramchandra Medical College during the COVID lockdown. I learned 3D designing, and I had all these MBBS students there who, some of them were interested. So I taught them not just Ophthalmology, I taught them 3D designing, AI, smartphone, so many things. And they came to me, told me that they want to do a project. This was one project which I made them do. I asked them to search for something. They searched and said, "Sir, we saw something called punctal plugs. Can we do that?" So I said, "Okay, how can you make something innovative from that?" They came up with the idea. They drew this 3D design themselves on their iPads, and we 3D printed it, we published it, and all these things could be done. And this is the glaucoma drainage valve, the RD equivalent which we printed. We practice surgeries using that. And that helped us in their the GDD surgeries, and all these things are available. Of course, there are so much more to talk about apps. I don't want to waste more time on that. But if anybody wants to, if this is the recorded thing, you can just pause the video. So I'm going through it. Tuck, tuck, tuck. Yeah, pause the video and look at it later. So thank you for listening to me, and thank you, YOSI, for this session.
Thank you so much, sir. So what is the app that you use to design these 3D models?
Yeah, so there are several apps which you can use. I use the free software, free and open source software called FreeCAD. And that is something which is not very great, but that is something which I use to develop all the models which I have shown here. And if you want something slightly better, there's something called Fusion 360 that is technically free for students. So if you have a .edu email address, you can get it for free, or you know where to get it for free. And you can always use several other software. One is Rhino. Rhino is also pretty good, RHINO. And yeah, you can use SolidWorks, you can use AutoCAD. But if you want to have the officially free one, FreeCAD and
so
Tinkercad.
even Windows 10 and Windows 11 has a Paint 3D, which comes pre-installed, and for simple 3D diagrams you can use that and import those images in PowerPoint also, the way you were showing.
Right. And speaking of free, so have you considered monetizing, or are you monetizing any of these innovations?
I am monetizing the 3D printed fundus camera, the foldable fundoscope, but these designs I want to let it be free for everyone. So these are going to be CC-BY, that is Creative Commons Attribution, but non-commercial. So CC-BY NC. Some of them are NC, some of them are not. So you can use it. Just give credits to me that this was originally designed by myself, but you can use it.
Right. Thank you so much, sir. Thank you. So we'll move on to the last talk of this session. I'd like to invite Dr. Zain Khatib, sir, to speak on frugal innovations in refractive surgery.
Yeah, thank you, YOSI, for the opportunity. But Dr. John spoke in general. My talk is, related per se to refractive surgery. So I think since not many of us are doing refractive surgery here, I'll just try to keep it as simple as possible and try to explain what I have done. Basically, refractive surgery we know is a very industry-driven branch. So doing frugal innovations is that much more important in this field, since we need to do things ourselves to solve problem rather than you will give it to the industry. They'll give you a heavy bill for it. So I'll just talk about 3 problem statements that were there and which I addressed with small things on my own. So the first one I think is something really important. That is the protection of the retracted LASIK flap and hinge while doing the excimer laser ablation. So whenever you have a large ablation zone, be it in hyperopes or astigmatism, you can ablate the undersurface of the retracted flap and the hinge, and this leads to really bad coma. So I just came up with a very simple design, gave it to Epsilon, and I got a kind of cataract globe stabilizer slightly modified and made it into a LASIK globe stabilizer. Now, why I say globe stabilizer is because the purpose of this instrument was not only to protect the flap but also to stabilize the globe. So, modern laser machines, they have eye trackers which move along with the eye, but there is a small latency, and that latency period leads to terrible aberrations. So it is extremely important that the eye is well centered during surgery. So I'm actually in the process of collecting my data and publishing. So you see here the 2 laser spots are slightly defocused. I use the instrument to just press down slightly so that it focuses, and the head of it is protecting the undersurface of the flap. And now, we are going ahead with the ablation. It's well centered, focused, and the flap is not getting ablated. This is a hyperopic treatment. You can see the flap is, would get ablated if the instrument wouldn't be there. So if you see my instrument, you can see the crater in the center of my instrument is what the instrument has taken by laser, which would have otherwise gone on an undesired portion of the flap, and the patient may not present in terms of loss of visual acuity, but these are the patients who we don't understand why exactly they are having problems post-op. This is, just to show you how we track the centration after surgery. So the last one shows you that if it's well centered, that is where you want to achieve after every excimer laser ablation. Right. So that was one of the innovations I had made. Now the second one is, again, it's a continuation of this. If at all you have a patient who's 6/6 post-op and they are unhappy, they have glare, halos, night vision problems. Okay, we have tests like, your modulation transfer function, Strell's ratio, point spread function, aberrations, but these are all objective. How is the subjective way that you can assess whether a patient is happy or unhappy? The only test that we have is contrast sensitivity, peliropsin, and peliropsin actually doesn't test contrast sensitivity, it tests contrast acuity. So if a patient has very, very low contrast, then only it will be picked up on peliropsin, and slight changes in contrast will not be. So this is the test. You need grating acuity. You need to show sinusoidal frequencies at the standardized ones are 3, 6, 12 and 18. And once the patient is able to identify the sinusoidal gratings, you have to plot it on a chart like this, and this is called as contrast sensitivity sinusoidal grating. It is very useful to pick up if the patient is unhappy. It actually correlates with modulation transfer function, but in a subjective way. So this device which measures this is called as CSV1000. It's by only one company called Vector Vision in the world, and the company distributing it in India is called Jutron Vision. So what is the problem? The problem is that this device costs 7 lakhs. So you're not going to pay 7 lakhs to test contrast. So you have to take that chart, you have to test it, and then you have to manually draw it on the sheet that they give you for the plotting. So I decided to go ahead and make this on my own. I used PowerPoint. I just got all the gratings in order. I adjusted the screen brightness to match what is the set 85 candles per meter square, and I've been using this this thing on my own. And I even designed a Excel software where you don't have to manually draw it. You just have to feed in the score and the software will give you the chart. So this is something that is really useful for measuring whether the contrast sensitivity of the patient is good or bad, and it actually picks up even if you've got a multifocal IOL which is giving the problem. You can see whether the contrast is actually low or no. So that was the second thing I was speaking about. The third thing is slightly more complicated, but I'll just keep it simple. So this is some kind of passion project of mine, say for the last 2 years or so. Understanding astigmatism. It's a complex topic, but many times we treat the patient with the refractive error and we realize that they are left with a post-op cylinder for no reason at all. Why should this cylinder be there? The reason is because astigmatism is complex. It comes from different parts of the eye, right from the brain up to the anterior surface of the cornea. And it is important to understand which part of the eye is contributing to the astigmatism before we treat the patient. So in simple terms, the difference between the corneal astigmatism and the total astigmatism is given the name as ocular residual astigmatism. And patients who have high ocular residual astigmatism, there have been enough studies to show that they are the ones who, have the post-op residual cylinder. So I designed my software to basically understand from where the astigmatism is coming and correct it adequately. So just to give you an example, for this patient who had minus 1.75 diopter cylinder in both eyes, she was a 36-year-old female. If you just see the her corneal astigmatism, it is 0.45 in the right eye, 0.25 in the left eye. This is like really low, and her manifest cylinder is 1.75. So my software gives you the components of the astigmatism. So you can see here most of the astigmatism is coming internally from the lens, and then it uses vector mathematics to give you what should be the final correction. And in this case, in the right eye, instead of 1.75, the software is set to correct 1, and in the left eye, instead of 1.75, the software is set to correct 0.75. So this patient was extremely happy post-op, and you can see that the cylinder post-op is also 0. So if we would have gone ahead and corrected 1.75, she would have definitely got a residual cylinder left. So this is something that I've been working on for some time, and I won the ASCRS award last year for this software. So these were some innovations related to refractive surgery that I've been doing, which I wanted to share. Thank you.
Thank you so much, sir. I hope you're planning on starting a refractive fellowship program if you haven't already, because this is really game-changing things, and I think the last thing just went over my head, but regarding the other things, I think a lot of people would benefit from.
Unfortunately, the whole idea of fellowship in India is that we should have volume of surgeries. So if you don't have volume, you can't start a fellowship.
Right. So that brings us to the end of this session. I'd like to thank everyone who participated, and I think we can conclude. I'd like to invite everyone for a group photo.
सीधा सीधा लो ऐसे